This is a case of laparoscopic cholecystectomy in a 39 years aged female patient suffering from acute exacerbations of chronic calculous cholecystitis with irregular menstruations. We suspected the endometriosis. Now, through the umbilical port, we introduced the telescope 30 degree 10 another epigastric port, and mid clavicular port and the anterior axillary port are going to be inserted. Mid clavicular and the axillary ports are 5 millimeter each, whereas the epigastric port is 10 millimeter and the umbilical port is 10 millimeter. Now, after introduction of this right anterior axillary port 5 we are going to inspect the abdomen thoroughly. You can see the omentum and the small bowel lobes which are visualized, and you can see the ascending colon near the hepatic flexure. The distended gallbladder you can see, which is uh, quite obvious, and the liver margin is thinned out at the gallbladder fossa where it has been attached with the liver. So hugely distended gallbladder you can see protruding out of the liver margin. Now the fundus traction towards the ipsilateral shoulder is going on, and see the additions of the omentum with the undersurface of the gallbladder due to these acute exacerbations of the chronic calculous cholecystitis. Thus, our first job is the additional lysis. With the help of the bowel grasper and the monopolar diathermy hook, we are doing our job of additional lysis. And you can see the part of the stomach which is get adhered, so be careful here. Now we are changing our traction and counter traction due to this distended gallbladder. Now again we are introducing and produce the traction. The stomach has been adhered with the calottes, so we are little more cautious during application of this diathermy hook. So small birds we are planning. Now we are separating the stomach from the calottes and the CVD. You can see the common bile duct and the rubeus sulcus you can see on the right side, and our dissection remains always above this rubeus sulcus, not below it, otherwise inadvertent CVD injury may happen. So we are constantly changing our traction and counter traction. Again traction has been implicated, and Hartmann's we are pulling it downwards and laterally and going to separate this anterior calottes. Initially we have done the posterior calottes. Now we are concentrating over this anterior calottes, and you can see the cystic duct, and we are little more separating the peritoneal lining. You can see the bleeding. The part of the cystic artery has been diathermized, and there is injury, so we have to control this bleeding during the additional lysis. So we will control it with the help of the clip applications. we are trying to apply it, but it will not stop. So we have to more cautious, and we are just grasp it with the help of this bowel grasper to make it stop, and make it patience little more, and we are going to apply another clip, and inadvertently we will at last be successful. You can see again after application of the clip position is not perfect, that's why again bleeding happen. So we again trying to stop this bleeding, and we are making a clip, another 300 liga clip, but bleeding is coming from above. So we are again replace and make the compression with the bowel grasper, and at the same time we are going to some extent dissect this area and properly visualize the cystic artery end, and trying to clip it out so that we can pinpointly stop this bleeding. So again compression applied, and clip has been loaded, and now we are going to apply it and see the bleeding has been stopped. So during cystic artery it may happens during the additional lysis procedure, but not to be tensed enough. Be patient, and gently press the area, and by that time you will load the liga clips and apply it. Now we are again doing our job of additional lysis and making the anterior calots. You can now see the separating the cystic artery and the cystic duct, and making it the critical view of safety or Strasbourg. After proper making these separations with the help of this Maryland forceps, we are again enlarging the window in between the cystic artery and the cystic duct, so that we can make it arrange to apply the clip. Sometimes you may suck this bile from the gallbladder, but it depends upon the surgeon's choice. But I generally prefer not to suck it out initially, unless otherwise there is chances of slippage of stone from its normal position, and it may dislodge into the CBD, creating some problem because of the such sudden release of the pressure of a distended balloon. The stone may be dislodged and creating more problem. But when, if it is not possible to eventually grasp the gallbladder, in that case we have to do this bile to be sucked out. So we are now applying the 400 liga clip. You can see the cystic duct is quite distended and thick. So 400 liga clip has been applied. Total 3 clip, proximal 2 and distal 1 we are applied. Now we have to cut this cystic duct in between proximal 2 and distal 1 clip. So we are just cutting it small, millimeter by millimeter, and during cutting we have to look for any stone at the stump present or not. So here is the stump is clear and no bleeding at all. During separations of the cystic artery, we have to be cautious here, and we are using the diathermy distally and taking away from the liga clip so that the current will not be transmitted towards the clip. Otherwise, the part that has been clipped at the cystic artery will eventually slumped and creates problem with active bleeding in postoperative period. So current should be remain away, and we are now double secured this area with another 300 liga clip proximally towards the cystic artery. This clip is not just sleeping, the previous one, so we are just taking it out, the previous cystic artery clip. It was applied first, so we have to take it out, and another clip has been applied. Now the gallbladder is dissected out of the liver bed. Before doing that, we are double securing this cystic artery pedicle so that in post-operative period no bleeding will happen, and we are just checking it twice and see the 400 clip remaining over the Hartmann area. Now another 400 clip we are going to apply near the pedicle. Now we have to remove this previous two clips. We are not properly applied. Because you can see it just like cross finger, the two limbs of the clips are remaining. That's why we have to remove this two non-occluding clips. With the help of this stone holding forceps or grasper, what may be present. Now we are using this stone holding forceps to hold this clip. One by one we have to remove it. Another clip you can see. Now complete clip applications. Till now no active bleeding is there. And total operation is done under spinal anesthesia. The beauty of the spinal anesthesia is after postoperative period you can allow orally even after 2 hours, whereas in general anesthesia you have to give any water at least 4 hours post-op, and you can discharge the patient either on the same day under spinal anesthesia or you may observe it only for 24 hours. So this is the beauty of the spine anesthesia under which we are operating. Thus you can see the diaphragmatic movement. All laparoscopic surgery we are doing is under spine anesthesia. Like laparoscopic hernia, appendicectomy or gallbladder surgery, all under spine anesthesia. Now the separations of the gallbladder from the liver bed is going on, and we have to separate it from the liver bed and making the proper hemostasis. Just only the fundic area we have to separate. So you can see, without deflating the gallbladder, we can easily separate it from the liver bed. And small birds is main thing, and stick to the gallbladder wall, not towards the liver. Otherwise inadvertent injury of the liver sinus may happen, and sometimes sinus may open out. Now the last part has to be removed. Now the gallbladder is separated from the gallbladder bed of the liver. And now our purpose is to remove this gallbladder. You can see from the wall small bile is leaking out. So we are inserting the endo bag. And within which the gallbladder has been introduced. In transparent bag there is glaring and glittering problem. That's why I always prefer to use the gloves as an endo bag. And gloves are to some extent quite sturdy, and these endo bags, during traction it may torn and sometimes bile may come out, but in gloves, due to the elasticity, and it is very least chance of tear. Now we have to remove the gallbladder through the umbilical port. The camera has been inserted through the epigastric port, and we have to, now the endo bag has to be removed through the umbilical port, and 30-degree 10 mm telescope has been introduced to the epigastric port. Now the endo bag has been removed along with the gallbladder through the umbilical port, and after that we will do the proper peritoneal toileting that has to be needed, the main surgery, not only the gallbladder extraction but also the thorough peritoneal toileting, because all you know that biliary peritonitis and fecal peritonitis are the devastating and life threatening. So thorough peritoneal toileting is the must, as the bile is leaking from the wall and large impacted stone remains within the gallbladder, so it is very difficult to remove the gallbladder along with the endobag through the port. We are trying to crush the stone after sucking out the bile from the gallbladder, but not able. Yes, crush and sucked out the stone and the endobag has been removed. And you can see the bile is leaking from the endobag itself, so we have to properly and thoroughly clean the abdomen. So that biliary peritonitis will not happen and the post-operative recovery will be smooth and patients no paralytic ileus happen. And we generally don't prefer to give drain unless indicated. Thorough peritoneal toileting followed by proper abdominal peritoneal dryness is main thing. We are just washing this bile with the warm normal saline, because if you don't clean it properly, it creates some reaction, inflammatory reaction that causes inflammations and adhesions post-operatively, and that may lead to in future subacute intestinal obstruction. So proper warm saline toileting is a must after gallbladder surgery or any kind of abdominal laparoscopic surgery. And all the blood mixed with normal saline has to be sucked out. Thorough toileting is going on at the gallbladder fossa. All the element has been sucked out, all the blood clots, because blood clots may create abscess formations later on that causes adhesion and leading to subacute intestinal obstructions. So be cautious. Thorough toileting and proper removal of the clots is mandatory, not from the liver bed. So we are just observing the area where we have secured the clips from the cystic duct, cystic artery bleeding. So we are cross checking it. All the collections has to be removed, all the fluids, as we are not giving any drain, so abdomen should be properly dried out. All the fluids has to be sucked out, otherwise it may creates intra-abdominal abscess formations. As much as possible fluid has to be sucked out and abdomen should be dried out. All the fluids may be collected at the pelvis or at the hepatocele pouch of Morrison. So this area has to be properly sucked out. You can see the toiletry fluid is present also here. So we are going to suck, and you can see the good bowel movement. That's the beauty of the spinal anesthesia. Under general anesthesia, due to the some anesthetic drugs, the post-operative ileus may happen. But in spinal anesthesia, that kind of drugs are not used. So post-operative IPS recovery is very smooth, and you can allow the patient to take foods even after 4 hours operation, and only water, liquid diet 2 hours post-operatively. So we are again see the area for the last time. Any bleeding, any hematoma, any bile present or not, coming out or not. We are now again cross checking the liver bed and applications of this Abgel at the liver bed site for better hemostasis. So we are going to take those Abgels at the liver bed at the gallbladder fossa. But remember, after proper securing of the bleeding, you can put this Abgel. If bleeding is present, don't put Abgel and coming out. Just it will be devastating. First secure the bleeding, and if you may have any small doubts, cross check, and after that 100%, 200%, when you are sure regarding no bleeding will come out, in that case you may apply Abgel for small oozing or something else, because all we know cystic artery bleeding cannot be controlled with the Abgel only. So first secure the bleeding, and after proper sureness of your that the area is clear. Now we are going to see the uterus. You can see the adenomyomatic changes of the fundus part of the uterus, and the urinary bladder is distended, getting distended, and both anterior and the posterior wall there is whitish changes. It is the adenomyomatic changes of the uterus that lead to some contraction problem during the menstruations, resulting bleeding. At present, the adenomyomatic changes is an early, so we should not do with anything, and the family is not complete. That's why we are not supposed to do anything with the uterus.